April is Alcohol Awareness Month. And why is that important? Alcohol addiction and abuse really does claim thousands of lives across the country each year. I know many of you are calling from even out of the country. It destroys marriages and friendships and careers and really a person's basic health and safety. In the United States, almost 21 million Americans have at least one addiction, and statistics show that only about 10% of them actually receive treatment. So while alcohol is the most widely abused substance in the United States, there are a variety of other substances, process addictions and impulse control disorders that really impact our communities. Gaming, technology, gambling, pornography, exercise, food, shopping, like the list really goes on and on and on. And I think that I can safely say that in some way, shape, or form, addiction really does touch everyone, right? Across all spectrums, economic classes, treatment programs. And it doesn't just impact and hurt the person who is battling it, but it impacts all aspects of their lives, including their family and their friends and their, relationships that they have, like siblings grow angry maybe with each other, and mothers cry, and fathers wrestle with helplessness, and friends grapple with anxiety and confusion, all of them wishing that they knew how to make it better. Like, how can we make it better? How as therapists can we make it better? And so several studies have shown that trauma does increase the risk of developing a substance use disorder, and substance abuse increases the likelihood that people will experience trauma. So our presentation today will highlight the intersectionality between trauma and addiction. And we have an incredible speaker, Steve Sawyer, who will take us deeper in our understanding of this connection. So without further ado, I'm going to introduce Steve Sawyer. So Steve is New Vision Wilderness Chief Clinical Consultant and the co-founder of Brain Spotting International. He is the senior trainer for HeartMath interventions and resilient heart programs, and is the co-author of Wellbriety Mending Broken Hearts. He is a dual licensed psychotherapist filled with passion and knowledge surrounding the intervention and change process. And his experience comes from 2 decades of intervention with tough to reach client populations in therapy settings ranging from, residential, community-based, outpatient, as well as wilderness therapy. He is a trainer of several unique therapeutic models, including brain spotting and HeartMath, and he co-founded New Vision Wilderness therapy programs with a trauma-informed and clinical focus with 3 locations spanning the country. He continues to work as a core therapeutic training development staff with the Institute of HeartMath, receiving their Humanitarian Heart Award in 2018, and he is a leading active international brain spotting trainer. So along with his training of phase 1 and 2, he developed the developmental trauma-focused model of brain spotting, and Steve's native-focused work as a Wellbriety Mending Hearts trainer and Generation Red Road facilitator. He spends time amongst trauma-focused treatment masters like Gabor Mate and Bessel van der Kolk, and his trainings are recognized nationwide for cutting-edge therapeutic techniques, science, and inspiration. So, Steve, with that being said, would love for you to take it away and share your knowledge and expertise with all of the 102 lovely people who are on this call. Thank you.
Yeah, wonderful. Thank you, Sabrina. Thank you for the introduction. First off, I just want to thank you all for being here, taking your time out, a lot of you on your lunch hour to be with us. I always feel honored to be asked to share on anything and to be able to spend this time with you. I value that. And I hope that you walk away with that same feeling by the end of the conversation. To introduce myself to the First Nations relatives that are on here. I'm coming to you actually live from Dahlonega, Georgia, where our First Light program is at. I stand on the land that is the people, oftentimes people associate Georgia with the Cherokee Nation, which has a very strong presence here, but I want to recognize them as Coyhis too, as the primary people of this land that I stand on right now. And to formally introduce myself to the Native relatives that have attended today. So I'll just introduce myself to you with an open heart and a handshake. All that stuff that was mentioned that I do, I'm blessed to have people that have taught me everything that I know, and I want to acknowledge them very early on in this presentation. Inside of that, though, I want to correct the director a couple things on there. I didn't co-found Wellbrighty. I'm one of their trainers. I didn't co-found Brain Spotting either. I'm just one of their trainers. So I want to correct the record there. I don't know where that came from exactly, but these things happen. So I am that passionate that I'm that invested in Brain Spotting and Wellbrighty both. However, I'm definitely not a co-founder to either of those, but to clarify, I am the co-founder of our wilderness programs that are a part of Embark Outdoors. So that's my primary role and my work day to day between our Georgia program, First Light, our Wisconsin program, New Vision Wilderness, and our Bend program, Deschutes Wilderness Therapy. I live in Bend, Oregon, contrary to how often I spend time there. That's where I actually live. And so, to move forward, I'm going to pull up a presentation here to work through. Feel free, along the way, if something catches you, to snap a picture of it. And I have to also acknowledge that inside of this presentation are materials that are clearly owned by Brain Spotting International, that are clearly owned by HeartMath. And so I have permission as one of their leading, trainers in both modalities to utilize these things. So I just put that out there, giving that credit where the credit is due. So I'm going to start my presentation here now. And so when they proposed this topic for me, many of you that do know me on here, this is a big passion of mine, and has been since very early on, and it's been something I've been investigating a lot of my life, to be clear. I've been a little bit more open about my recovery history and those kinds of things in my presentations lately. And this all makes sense to me at an internal level. And so, that's where some of my passion in this topic comes from. But getting to the core, both trauma and addiction, and then coinciding, is a process, right? To highlight that, to understand that this is a small jump into the world of this work in this presentation, but it will get you thinking, and hopefully you'll walk away with some things to kind of go and investigate. So first and foremost, I want to acknowledge my elders that have guided me in this knowledge all along. And here are a lot of key people that I've been able to be blessed to spend time with, to teach me. I have learning issues. I don't read a lot. And so I learn by mentorship, and I pursue aggressively my mentors. And so I'm grateful to have had these people be a huge part of my life. You have Gabor Mate there. David Grand and I are good personal friends. Demir Demont is the neuroscientist on the upper right, from Germany. We have Stephen Porges in the lower left hand, who taught me a lot about, enacting the trauma stress response and our work with Brain Spotting. There's a lot of people on Brain Spotting that are on here. Two Native elders that have really shaped Native focused trauma treatment from a cultural lens. Don Coyhis, the founder of Wellbrighty, that's him down here in the lower center. And I get to spend some time with him in a couple of weeks here, but, love their work so much, became one of their trainers. Gene Thinelk from South Dakota, very powerful teachings in the Generation Red Road work. Joe Spinazzola, I'm going to be talking a lot about developmental trauma, and he really helped me with the research aspect of what we are finding about that. And yes, there's Bessel. So these are all the people that shape my lens at how I view this throughout time, paired with that personal experience, paired with a lot of experience of working on this as a co-occurring process. When we started New Vision Wilderness in Wisconsin, the population we're going to talk about here was my group for many years. And still work in that adolescent treatment world, focused on this co-occurring process. We talk about co-occurring a lot in the substance abuse field now, not as much in the mental health field oftentimes. And what does that mean to be co-occurring, to exist in the same time together? And so we're going to talk about that a lot. Sabrina really mentioned this. The research is pretty darn conclusive. This was a really powerful study on that. You can pull this out of the Journal of Pediatrics. This study examined 8,613 ACE scores, okay? Narrowed down to a number of individuals, and then looked at the correlation between drug initiation and the process of having high ACE scores in your history. And the results were astounding, 2 to 4-fold, okay? So twice to 4 times likely to go into that. It's right here in the results section, that a youth growing up that has high ACE scores is 2 to 4-fold likely to step into drugs and alcohol. That's the outcome of 8,613 case situations. So the numbers are very conclusive and clear about this process, that early childhood experiences. So those of you that don't know what an ACE score is, most of you on here probably do, right? Adverse childhood experiences. And there's an assessment for that. I'm all about the revolution that's happened with looking at this more carefully in the medical field and in the mental health field. But please be wise. If you know somebody has an extensive amount of ACEs history, it is not trauma informed to have them sit in your office alone and recall 10 of the worst traumas they ever had in their life sitting by themselves. So I do like to say that when we talk about ACE assessment, please do it with them and stop when they're overwhelmed. This is part of the first part of trauma-informed process of looking at early childhood adverse experiences, is that if we ask them and assess it, we're asking them to recall it. That's a big deal. So a person who really has been laser focused on this for a long time has been Gabber. If you haven't read his book, In the Realm of Hungry Ghosts, or listen to the audiobook like me, you know, a lot of it is looking at the structure of a human being, right, that exists when we grow up with childhood experiences that are problematic, and this hunger that comes from behind that for relief. And we're going to talk about that a lot. The main theme in a lot of his work is not why the addiction, but why the pain. That doesn't mean we don't treat the addiction element too, especially when it's co-occurring, but we have to see addiction through the lens of also seeing the pain that's underneath it. These conversations led to me and Gabber, and thankful to Embark to be on a journey together. We did 5 panels across the country together, talking about this process of work when we have to work with the aloneness factor that comes from growing up with childhood experiences, adverse childhood experiences. That aloneness sets people up for that pain, and then that pain and that sense of that pain and relief of that pain then fuels people reaching out for the drugs. A lot of times when people talk about treating co-occurring, it's like, what do we start with, the chicken or the egg? And it's more complex than that. It's all wired together, and hopefully you walk away with a better understanding of that. I loved I think this term's been around a little while, but this was really a highlight that he brought up in every single presentation we did together, which is a primary premise inside of the addictions field work comes through the 12-step programs that have had an incredible impact for substance users throughout time to find sobriety, to find clean time. But this idea of disease, and then taking that apart, dis-ease. We're going to talk about what dis-ease is about. Disease, right, is this unhealthiness that's inside of our body, our norm, etc. And then starting to look at the nervous system's experience of this lack of ease. Where does that come from? And when we can't find ease, what do we reach for to find it? We're going to talk about that. Another person who profoundly impacted the substance abuse treatment world, coming from a place of looking at the roots, peeling to that core level, looking at what's below the layers. Don Coyhis' work with the White Bison organization, of looking for what's below the surface layer of what we interact with. We interact with somebody who's an alcoholic, a heroin addict, a meth addict, etc. But when you look below the surface layer, and we peel back those layers, You see anger, guilt, shame, and fear. And we're going to take that and really define that down in a neurological way in this process. But Don's work with that has been very powerful because he also integrates culture as a part of that. And this is one of the most kind of recognized recovery programs in Native America for Native people to find sobriety. But this has been around for a long time. He wrote this stuff like 40 years ago, and the underpinnings of thinking this way about addiction have been around for a while. So rewind a ways, and we had an event that some of these people were a part of that was the Campaign to Heal Childhood Trauma. And we went on this bus tour. So you can see over there, we have golden retrievers on our bus and all this other stuff. We went on this journey to share the story of how profound childhood trauma is. So much of our mental health treatment field has been oriented around treating PTSD, right? Post-traumatic stress disorder. That process of treating PTSD, it looks different than what the research has been indicating childhood trauma manifests like. So we use this word trauma, we're going to peel that back a layer and say, well, not just PTSD or just the word trauma, but let's look at the difference in a manifestation for these ACEs individuals that have high ACE scores. Their nervous systems look different from oftentimes what PTSD looks like. And kudos. So to go back to that slide, me and Joe Spinazzola developed this piece of this presentation together, pulling research apart to tell the story of what this difference is in the nervous system, this lack of ease that comes from adverse childhood experiences. Inside of this, the study, The Unseen Wounds, was done by the National Childhood Traumatic Stress Network. That's what the NCTSN. I meant to spell that on the top of the slide so you guys could reference it or look for it. If you search Unseen Wounds study, you can find it very easily. 5,616 youth that had exposure categories of either one or a combination of psychological maltreatment, sexual maltreatment, physical maltreatment. Then taking a look at this and pulling it apart, looking at it even more closely. And I have, there's other slides that go with this, but for the time frame, we got to hit a couple of the key ones. So Joseph, in his examination, he's on the committees with that organization, but also wanted to boil it down even more and got really specific in this study, where they took it and they pulled it down to an N from 5,000 down to 1,699 individuals that had high ACE scores, and looked at very specific symptom indexes, meaning how is it manifesting in them in their lives, and really studying it under a microscope or a magnifying glass. And when you look at the criteria or the manifestation, the criteria that were associated with PTSD, which we'll talk about more in a moment, were way down on the scale compared to other things that were associated with having these adverse childhood experiences. So out of all of these criteria, it's not until about the 12th or 13th category that post-traumatic stress actually applies to these individuals, that there's a whole bunch of other categories we see more before that, or more commonly as an attribute of adverse childhood experience. So emotional or affect dysregulation, meaning my moods are dysregulated and I can't regulate my moods or my emotions well. Number one criteria or outcome, symptom. Second, attention and concentration. In the mental health field, one of the number one most common diagnoses is what? ADHD, attention deficit hyperactive disorder. And look, they had attentional and concentration issues as they were correlated specifically to having adverse childhood experiences. Negative self-image, how I view myself, and I view myself poorly. These are all attributes of and key elements of what does not necessarily fall loudly inside of the PTSD diagnosis. So we'll pull apart more. You can note all those other symptoms that are there. When we look at PTSD, it was formulated, and me and Joseph have many conversations even since that campaign about this. PTSD was formulated and researched coming out of World War II. And inside of that, very specific instances inside of the war were being treated. So there was a traumatic event and these other symptoms that were associated with events. when they, and specific events, an event or a series of events, when they start to look at ACEs, we start to pull it apart a little more carefully. It's a lifetime of being immersed in events in your earlier experience in life starts to affect the nervous system differently. I'll show you scientifically what that looks like in a minute, but you will know one word across 3 of the criteria for the diagnosis that they proposed to the APA, developmental trauma disorder. You can go online and search that. It's a proposed diagnosis to the APA right now. It has not been accepted yet. As flustered as I was, Bessel, the whole trauma center team was in uproar about it not being accepted. Joseph reminded me that to get PTSD as a diagnosis, it took 15 years of research on it before it was accepted. So hopefully we can get the developmental trauma disorder research to the forefront and as a diagnosis sooner than that. A lot of you can influence that by pushing on that in your national organizations, et cetera. But there's one word that runs through 3 of the criteria for developmental trauma disorder: dysregulation. Dysregulate, to not be able to regulate something. And you have 6 criteria of that: relational dysregulation, attentional dysregulation, somatic or body dysregulation, emotional dysregulation, my sense of myself, dysregulation of my sense of who I am. This all comes because our caregiver helps us understand that. So moving right along, why does all this matter? Why is that dysregulation so alive? When we're born into the world, we're born with a nervous system that has needs. Right out of the gate, when we're born, it has needs. And behind those needs, we have to be able to communicate them. We can't go and get our food ourselves at this point. So we were programmed neurologically to be able to express those needs. As the need is not met, the nervous system rises in its arousal. So it activates more and more and more until, right, a baby goes from being fussy. A lot of your parents on here, they go from being fussy to now crying. And the longer you parent, the more you realize you better catch the fussy before you're into crying, because it takes that much longer to try to get the system re-regulated. So you know all different kinds of fussy, and this is what attunement is. Being able to accurately look at your child and be able to say, oh, that's a hungry fussy. That's my diaper needs to be changed fussy. That's I'm just having a bad day fussy. And you can pull all 3 of those apart, and based upon your accurate response to that, you get the child gets a good experience, right? It's gratifying. You brought me, I was hungry. You brought me food. Thank you. If I'm crying because I'm just fussy today, and then you keep giving me food and I'm just tired and I need a nap, I'm going to get more and more aggravated. So the arousal, when a caregiver is not responsive, which is the case in a lot of these adverse childhood experiences, it's parents or caregivers that can't be as attuned or accurately respond. The nervous system gets louder, 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 and it gets stuck there. Is kind of simplifying this down. It gets stuck there. It's hard. The caregiver's lack of responsiveness turns the nervous system into some permanent imprinting of this dysregulation in those 6 different categories. We talk about trust and rapport all the time in therapeutic world, but what actually creates that? The fact that you positively impact their life accurately, and that you're giving them something that they're actually looking for. They get relief. So my nervous system arouses, I come into therapy, you doing good work that gives them a gratifying experience actually gives them trust with that experience. A healthy attachment cycle, the need is there, the nervous system arises, it communicates it, and then an attuned caregiver brings them the right thing, and then the nervous system settles down. And inside of that, they sense that connection to the caregiver. They're like, thank you for bringing me the right thing. And so inside of the elements of trust, rapport, all this is built by other human beings responding to our arousal accurately and in a good way. And inside of that, we sense connection to other human beings as a good thing. It helps me calm down when I talk to you about it. It helps me calm down when I say I'm hungry and we go eat and we respond to that. Attuned caregivers do that. Unattuned do not. So inside of the dynamic, if I have an unattuned caregiver, need goes up, arousal goes up. An unattuned caregiver, no, you didn't hear me. I'm hungry right now. I need to go eat. Well, why don't you just take a nap? right? The lack of accurate caregiver response gets the nervous system ramped up more and more and more. People that are coming from adverse childhood experiences with lack of attuned caregivers, maybe they're substance using, maybe they just have low stress management capability. So they're stressed all the time, so they can't stop their stress response in the world around them and be responsive to the child. Inside of that, throughout time, I don't know, it becomes unpredictable if you're going to give me what I really need to settle this down or not. So inside of that is the recipe of attachment and connection to the world around us. If I connect, I will feel better. When somebody has reaction to attachment, there's a diagnosis we have in clinical world called reactive attachment disorder. And I always reframe that every single time, saying reactive to attachment disorder. This is a picture of this when a nervous system has been met with an unhealthy, unattuned caregiver responsiveness enough times, or it's imprinted in a nervous system. When I think about somebody, a parent, this is an example of a child who's doing some self-regulation. We'll talk about that more in a little bit. Thinks about their connection to that parent, and their nervous system goes opposite to calming down. It actually activates. It gets more stressed, more aroused. And so when people grow up in adverse childhood experiences, met with relationship after relationship after relationship that's not responsive and bringing this calmness, they have to find a relationship that calms them down. And chemically, drugs, alcohol, both do that. So inside of that, this is the matrix of why the nervous system needs relief, of why people with high ACE scores gravitate towards 2 to 4-fold going to use substances. So now we take a nervous system and we bathe it in it over time in development. So these people that have 3 to 9 to, all the ACEs in there, this is what this looks like in the nervous system. This is what that word dysregulation looks like in a picture. It's all over the place. It's almost unmeasurable. This is heart rate stress testing from HeartMath's M-Wave PC program. And it's measuring they're just sitting there, and it's measuring their nervous system's ability to regulate, kind of go up and down naturally. A natural healthy pattern naturally goes up and down. This person's nervous system is all over the place. And by the way, red means it's having a hard time measuring it. So inside of that, you have up over here, down over here, up over here, down over here. It's up and down, and it's all over the place. And this is all over the span of about 4 minutes. So 4 minutes of looking at the nervous system, it's up and all over the place. This is what dysregulation looks like. The nervous system doesn't learn to find a steady pace, and it's just always kind of reacting and then trying to settle down, reacting and trying to settle down. So this formulates our sense of connection to people around us. And I don't have a lot of time to spend on this because of our timing. The ability for a person to connect to other people in those earlier experiences formulates how we connect the relationship around us. If we have a high ACE score, we can formulate different forms of attachment experience, and now we have an attachment style. A great book, by the way, about attachment style, I usually put the covers of the books in here and everything else, is Attached, the emerging science of relationship. And it talks from a pattern of a more romantic relationship, but I even work with parents a lot. I say, just plug your child's name into partner or, wife or husband or whatever your relational dynamic is in today's world, that attachment figure, how do I react to that? And this is my primary attachment style. So somebody who gets good responsiveness over and over again, and that attuned relationship is good, they're able to connect well to people and the world around them. They have a secure attachment style. That means, like, if I'm going to quit using drugs, it's fairly easy for me to just kind of reattach to something else. So I'm going to start exercising, and they can transition more easily. When you have these other attachment styles, when you start to look at addictions and how they manifest and somebody trying to stop, avoidant of conflict is a dismissive avoidant attachment, right? Conflict is a part of life. It's a part of formulating strong relationships. You have to work through conflict to have a stronger relationship in the end. And so the conflict with, confronting a friend who's using drugs is really stressful for somebody like this, because they're programmed to dismiss it and avoid it. So you know what? I'll just not tell them I'm not using drugs anymore, and I'll just kind of hide it. I'll stay in hiding the relationship. Fearful avoidant, right? I'm going to run away from the problem is a part of that process. And so they're trying to run away to something else, right? I'm going to run away to something to soothe or calm my nervous system down. Flight response, when we talk about trauma responses, I'm going to flight away and run away to something that helps me calm down because I can't get it in these relationships or I can't get it elsewhere. And so these people are highly gravitated towards drugs. I can escape. So literally when we say escape, like literally be able to run away to something that can bring down this activation out of my nervous system. And then this anxious, preoccupied attachment, it's like they go through a process of, oh, I'm really connected, or I don't know if I like this. And they go back and forth a lot. And so when we start to talk about the relationship of alcohol and drugs, it's like, man, I should quit, but I'm not going to quit. And I love this relationship with drugs. Oh, I hate it. And they're changing a lot of the time. So inside of it, there's different strategies we work with these attachment styles. And I don't have the time and detail to go through that. And the kind of detail you can sense can be done inside of this work, but it's more to frame up how those ACE experiences formulate, even how they connect to drugs. Do I connect religiously to it? Or am I able to pull away from it fairly easily? So many people do not account for attachment, understanding that an attachment to a drug is an attachment. It regulates my nervous system. It brings that arousal down. Instead of it just being an adversary, that there was a part of me that was really attached to the results of calming down my nervous system when I drank from the bottle, or I smoked something, or I snorted something. It brings down that arousal. So I formulate a very trusting relationship with that attachment because it's very effective. They experience gratification almost immediately upon demand. Literally in 30 seconds, I can feel better. How can I not trust that? Now, we know that the ongoing consequences that surround that are big. That's what we're trying to work with addictions work. But we have to address the level of attachment first and foremost. It's one of the most profound, one of the conversations I had with Bessel one time late at night after we'd presented at a conference together was, what's the most powerful neural pathway? And it's that attachment pathway that happens when a mom or dad holds a baby and stares into its eyes. And inside of that sense of connection that soothes us from very early on, if we have a good caregiver, drugs is just like that. When we're asking them to give up drugs, it's like, hey, this works really good on all this dysregulation of my nervous system and brings calm. They're sitting there with their drugs in their arm like this. I literally, throughout all my years of addictions work, I can't tell you how many times, man, if I could marry pot, I would, right? Like that's the devotion and connection that's behind them and their drug use, because it's so good at bringing down all that trauma arousal that's there. So inside of that, so the opposite of addiction is not sobriety, it's human connection, permeates in all forms of addiction works, including 12-step programs, etc., because they say, hey, come to us, we'll help you, call me. Here's my phone number, get a sponsor. But inside of that, if we just say, break the relationship, break up, and we don't work on the neurobiology of this arousal factor, at some point, the stress of that arousal that comes from the trauma is going to be so high that I got to reach for connection to something again. I'm going to reach for my drugs, or what are we helping to formulate for attachment in or elsewhere? And part of that is, it can be human connection. So this comes from our brain spotting trainers world, the idea of activation, meaning the nervous system's need to act. When you look at dis-ease, dysregulation is a form of needing to act in some way to protect myself, maybe from a relationship or from my sense of my body. So when we look at this word activation and you break it down, active, you break it down further, act, is that a lot of people with ACEs experiences have a lot of trapped, I couldn't do anything. My mom and dad were fighting and screaming and hollering, and I had to sit there and listen to it. They couldn't get away from it, for example. So that feeling of needing to get away the nervous system wires behind you. So here's what addiction looks like, right? I'm in stress and inside of the situation, oh, I have some level of stress that comes on, and you know what? I got an idea. I can get high. Eventually, a user starts to really obsess, like, you know what? I'm not getting relief right now talking to you about this. I really, really need relief. So their mind, and you can't, if you can look at the image closely, there's all kinds of words around this guy's head going on. His mind goes wild and is thinking about all these things. And what we call in the treatment world, obsession to use comes on. Like you start thinking about it, you start thinking specifically about it, and it ramps up, and it goes with that arousal getting higher and higher. The nervous system gets entrained and trapped in that. Eventually, the nervous system feels like it's on fire. We have to get this fire out now. And so if my nervous system arousal is really, really high, I have to reach for a fire extinguisher. If my nervous system's on fire, what's my fire extinguisher? And Gabber's really good about this. He shares about how for him it was CD shopping, right? There was times in my life that exercise was that I had to have something to put out the fire. It was not healthy exercise. It was like get relief exercise. So inside of that, as humans, when our nervous system is under high level arousal, it's programmed to reach for something to decrease arousal. What is your fire extinguisher? And that can become addiction in any form. Technology, it can become social media. There's all kinds of things that we can reach for when we're feeling that stress. Some of you can feel what I'm talking about. And it's like, I want to reach for my phone and see what's going on there. The phone becomes the attachment figure that brings down the arousal. If I see something on my phone, okay, oh, the world's okay. Now I had a gratifying experience with my phone. Now I'm calm. Nobody texted me that the world is on fire. I'm okay now. And these, by the way, become a very, very ingrained attachment figure for a lot of people. That's why these social media breaks are so important, and phone breaks are important. In the end, when we do it, if it's an unhealthy fire extinguisher, we feel bad about it. We're like, that wasn't good. I swore I would never do that again. And this is when shame hits the nervous system, which is really a complex emotional structure. I actually pulled out a lot of my talk on shame out of here because it is really important in addictions work, but it takes so much time for me to work that through at a neurological level. But it really depletes the nervous system in a profound way. And it also tells them, and Brene Brown says this, shame erodes the part of us that believes we're capable of change. I did it again. I'm never going to get this right. I can't change. Is the neurology what happens with that? We have to work on healing that part of the nervous system that goes there. And shame is a huge part of addictions and trauma work. Inside of trauma is inherent shame, and there's a whole conversation that we can have about that. Inside of addiction, there's deep and profound inherent shame, and that's a huge part of the nervous system's cyclical response, is to feel bad afterwards. So in a lot of addictions treatment throughout years, hit you with everything that makes you feel bad about your drug use. They did a thing in treatment back in the day where you sat in a circle and they called it hot seat. You sat in the middle and everybody told you everything you screwed up upon, right? And it was meant to like motivate you to stop doing drugs. But if you look at how this arc goes up and back down, all it did was make it go down, 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 down to a point where it really harms the nervous system. Doesn't mean that we shouldn't challenge or hold people accountable to what they do.
Steve, quick question from one of our guests. Can you repeat the part where you said shame erodes the part of us that
is capable, that believes we are capable of change? By the way, I literally had that quote on a slide, y'all. I had to like try to figure out what to take out, right? And it was hard. It was really hard for me to talk about addiction. To pull out my shame slides is like painful. But when we feel bad, we did something wrong and we really, really tried. We tried to do it different and we fail. It really erodes our sense of ourselves. I tried hard and I failed. I tried my hardest. So people have had the most amount of treatment. I've had 10 treatments and I still failed. The belief system that I'm going to do something different erodes behind that because I put my heart and soul into this, and then I failed anyways. So we have to be very careful in working with relapse when we come to addiction and trauma both, because underneath them, the shame actually stops their ability to change because it erodes their belief that they can, or that they're worth it, or that it even matters in their life. And I have a lot more on that, you all, but I got to keep on rolling. So to give you a little bit of a roadmap, when we start to look at that activation in the nervous system that comes from developmental trauma, addiction looks right next to it, runs a parallel road. I have this underlying traumatic activation from my ACEs scores trapped in my nervous system in dysregulatory patterns or unstabilizing patterns. So it's there a lot of the time. So already the reason that people with high ACE scores are more likely to use is they're already stress level above where most people are operating at if they do not have ACE scores. Then something brings it alive in that moment. And one thing with developmental trauma, it's really hard to know what it was. It could have been the tone of somebody's voice. It could have been how somebody said something. It could be a body motion of just looking down, and it had nothing to do with you, but I looked down, so you disapprove of me right now. That's how sensitive this caregiver relationship is. And this is the progress of what happens as I get a little more detail into that activation arc of I get more and more stressed. I have underlying stress already. I get an event that really stresses me out. So now I'm above my red line already. Like my level of stress is very hard to manage at this point. I'm going to restrain myself, though. I'm not going to smoke that cigarette. I'm not going to do it. So I'm going to temporarily try to resist myself from that. But my nervous system's already up there. It's saying, go do it now. So it becomes this cognitive body battle where the body drive inside our basic survival mechanisms often supersedes the desire to temporarily resist. My thinking in there deteriorates, so my strategy now starts to fall apart. I'm supposed to do this when I want to smoke a cigarette, but now I can't even think about what I was supposed to do. What was I supposed to do again? Then it's like, you know what? All else failed, seek the soothing, smoke the cigarette. So I compulsively, my nervous system goes from obsessing and thinking about it to midbrain stress response of go do it. That comes from our periaqueductal gray. For those of you that are neuroscience geeks, it tells us go do it. It steps into reaction mode. And once it's compulsive like that, it's very hard for people with severe addiction to stop anything. It just, they go and they act. They get that short-term relief. And shortly after they get relief, they're like, oh my God, I feel regret and guilty about it. I just smoked a cigarette. Then it's like, never again. I'll never do it again. Which right behind that is, wait, I said that last time. I said that last time, never gonna smoke a cigarette again. Shame hits, which sets us up and already activates us even more each time they go through the shame cycle. I have some slides on where I show how that cycle builds, but don't have time on it. So what happens in these relationships with people that are addicted come from relationships that are extremely challenged neurologically, right? Adverse childhood experiences means I struggle with relationship. Now I get in a relationship with somebody and my nervous system is set up. So this individual, who's probably a fairly healthy individual, is, going along in their day here. This is a heart rate variation test again, but this is being monitored while a person's in an argument or going up to the argument and afterwards. They're here. Then all of a sudden, the wife says, and by the way, all you wives out there or partners out there, I've told HeartMath, I'm sure it goes both ways. They're like, of course, we need to do that slide too, Steve, right? Which is the wife says something that is aggravating, just annoying. Wife said something gets under my skin. My nervous system already elevates just by being annoyed. So it ramps up. I'm annoyed now. And if you say one more thing, it just adds upon that annoyingness, right? So behind this, eventually it becomes full-blown conflict. And this shows you how intense the heart rate process is behind that conflict. Now we're in a full-blown argument, 150 beats per minute. And this couple, by the way, is sitting in a car having this conversation. So nobody's up and running at 150 beats per minute. We're blowing out towards each other inside of that process. And so inside of that slowly calms down, but we're still trapped here. The nervous system is still saying, yeah, this relationship stuff isn't so good. It stays aggravated for a while. And this is the brain preparing to fight the next fight. If this argument was with the tiger, I'm ready for next round 2 with tiger. And the nervous system stays elevated for a long time. And people with developmental trauma stay there. That's that slide I showed you before where the nervous system just stays there over time. So they're already prepared for battle. So people with high adverse childhood experiences are staying in a state of prepared for battle. So that's what this annoyance does. Even annoyance sets us up to be more aggravated when they say that one more thing, and I'm going to blow my top. So inside of that, the nervous system structure keeps our people with adverse childhood experiences and trauma prepared for battle, which means I already have an underlying feeling of need of relief. I need some form of relief. And the nervous system lives there. So inside of that, this is the relational aspect that has been programmed in. So now, while I was developing as a child and had adverse childhood experiences, I was taught to handle this conflict this way: scream and holler, to just say whatever and walk out and leave the conversation and leave you behind. Our programming for how we respond in an adult relationship, in this case, a husband or wife or a partner or whatever, is to respond by that early programming. And inside of that, we can have some unhealthy responses. So everybody said, well, okay, just stop using. Just stop the drugs, stop the cigarettes, stop the shopping. Okay. Some of you got in that pattern, right, of Amazon inside of the whole pandemic and COVID, right? It's like, oh, what do I need? What do I need? What do I need? It hit a lot of our developmental trauma people's nervous systems. What do I need? What do I need? I need something, and go on Amazon and search and literally click of the button. And then when the box shows up at your house, it's like, there it is. What I needed, it came. Amazon became an attachment figure for a lot of us in the span of the COVID pandemic, because I could get instantaneous results, right? Like within 2 days, what I want is right in front of me. So that's an externalized regulation versus saying, you know what? Stop. You don't need that, Steve. Just stop it. The key element was, do I have the capability to now regulate myself with the stop it so I don't have to go get relief somewhere else? And inside of the research, the ability to self-regulate is a huge element that was found to be a key part of it. In fact, when you look at the study and all the variables they looked into, the ability to access the ability to emotionally regulate myself was the highest indicating factor for addiction potential. So not only is adverse childhood experiences a key 2 to 4-fold variable, my ability to regulate myself, but we learn to regulate ourselves first by our parents being responsive to us. We actually get our sense of self through that. By mom staring into my eyes and talking to me, I'm valuable. I'm a person. She's over there. I'm over here. So with adverse childhood experiences behind it, that ability to self-regulate is more complex than people realize. This is a key attribute to long-term success, is not just that I get arousal and then I have somebody I connect to in human relationship. If I can, that's a really important part of the process, is to actually build the capacity. I'm struggling, reach for help and talk to somebody about it. Then there's the ability, like, I'm struggling and I'm able to regulate myself through that. And that's a lot of people start there, but the ability to even know to ask for help or connect with somebody to be helpful often has to precede this self-regulation work. And it's obviously very important. Part of the challenge is that for those that have grown up in adverse childhood experiences, are all these unhealthy patterns in relationship that have been witnessed, that even our relationship with ourselves can become tumultuous. That's what that research showed, right? Negative self-image. So I want to self-regulate, but I don't like connecting to myself because I'm bad. Think about that, just logistically. I'm bad, and then go to yourself and regulate yourself through it. So these are key elements that make addictions work tricky with people with a lot of trauma, is that the sense of self can be eroded. So it's like, well, my ability to reach and talk to someone and get soothing is compromised. and my ability to go in my side of myself and calm down is compromised. So there's these cycles, and this is the work of EFT, by the way, emotionally focused therapy. This is one of their dynamics, and Amanda Thomas specifically has done a lot of very cutting edge work, a lot with Jim Thomas around these patterns in addiction specifically. So to be clear, like what I'm talking about here is the infusion or the melding of people that are very addictions oriented and EFT. But if you are looking for a really good avenue to explore relationship and look through these attachment lenses that we're talking about, EFT does a very thorough job of doing that. And then we also got to get the complication of addiction in there co-occurring, right? It's not that you just struggle with relationship with others, you struggle with relationships with yourself and then your attachment style. And they really took this and mapped this out. And I don't have a lot of time to spend on this, but these dynamics that are at play in relationship. So we say, okay, 12-step people that might be on here, go and get a sponsor. That's a very complex process for somebody who has adverse childhood experiences, and people that, are in 12-step programs often talk about how hard it was for them to go to ask somebody for help when maybe I'm a withdrawer, right? No, I'd rather not deal with that. So I'm programmed to withdraw, but part of I need help, this conflict in the nervous system and being able to work through all these complex relational structures. And there's a system in place. They might not know what it is, but do I pursue people to get help so much that now they leave, right? I can't put up with this person who wants me so bad to help calm them. So the reverse is true also with that attachment and that caregiver cycle. What happens when I'm so needy and you respond to me and say, hey, I'm here to support you, that I just demand so much of your world that now you want to withdraw? This is how two people's relationships, the attachment style starts to play out directly with each other, especially with addiction. So getting help from another person is challenging when we look at relationships inside of the recovery dynamic of being in a marriage, etc. And being able to map out these dynamics is a huge part of being able to get some of this arousal met through outside relationship. So the ability to work with that is a part of the recovery and treating the addiction process. My problematic relationship with my sponsor, but also my relationship and my problematic attachment with drugs, and looking at this through an attachment lens and working on the relationships, both with the drug. A lot of it was like back in the day was the drugs, put them away, throw them away, be done with it. And that's a relationship that has been very reliable for them. So inside of that, do I try really hard and I pursue it? And then when it doesn't work well for me, oh, forget it. I'm just going to stop now. I'm not even going to try to quit. So these dynamics, again, I don't have a lot of time to spend on them, but reactivity towards relationship, attack mode. So there's a lot to this again, but I put this mostly in here for people to be thinking about this. They also have a relationship with the drug or the shopping or Amazon that we have to work strategically to map out on a relational level to give them the best ability to reformulate a different relationship based upon their adverse childhood experiences. So inside of that, we have to work on healing some of these cycles. So we have to work on a cycle of de-escalation. Each person in a relationship needs a different experience with de-escalation. Some people want to talk about it. Other people want to be like, just let me have some time alone. How do we work with that cycle? So each individual in a relationship having their plan around de-escalation. Then restructuring. Hey, usually I'm chasing you and wanting to talk about it. You're taking off. Let's work on restructuring how we work together in this time frame. And EFT is very, very strategic in that. And again, there's a lot to that image over there. I want to show you how complex this work can be at looking at a relationship literally through 5-6 different layers. And then working to integrate it into our lives is a different way of being. Now, part of the self-regulation piece too, so we've covered some of how we have to work on these relationships and arousal cycle, is also being able to manage our inner world and teaching our clients how to do that, and not imagination stuff. What impacts the midbrain? This is why I'm such a strong proponent behind HeartMath and work with them so closely. So we can empower them to connect to themselves. And then we're going to wrap this up. This is the last couple of slides. Heart lock-in is a specific technique trademarked by HeartMath, which is really about locking in on our sense of heart and body and self. And specifically, there's a lot to HeartMath around working with the electrical system that's in our body, and specifically a neurological structure known as the heart brain, just giving you some things to look up and read about afterwards. But heart lock-in technique is a way of working on myself first and then re-engaging in a relationship. So I encourage you all to take a moment and think about a relationship that you're struggling with. You know, it could be a relationship at work, it could be a relationship at home. And just being mindful of that relationship and even noticing in your body as you connect to that relationship, kind of what happens for you, right? Generally, there's some dysregulation, some dis-ease that comes online when you think about that relationship. So we're going to strategically work with that by first coming back to self. So now you had a sense of that relationship, the aggravation with it, shift your attention to your heart area. For some people, it helps to put their hand on their heart. For some people, it's not helpful, but for some people that can be helpful. Bringing your attention to your heart area, bringing your attention now away from that relationship and bringing it back to self. While you're doing that, breathing slowly and deeply. So now monitoring how you're breathing. Our tendency when that relationship is contentious is to tighten up, breathe shorter, more rapidly, holding your focus on your heart in that area as you're noticing your breathing, doing those both together. Now that you brought your attention to yourself, work to activate or bring an awareness or sustain a genuine feeling of appreciation or caring. Appreciation for something in your life. Could be a dog, could be a child. And really notice as you're focusing on your heart, that sense of that. And while you're experiencing that, while you're feeling that, take a moment and now try to send, being mindful of the connection that you feel in your heart into that feeling of appreciation, that felt sense of that, feeling that and sending that to that other individual that you're actually in struggle with. As you're sending that heart connectedness to them, you start reformulating the neurobiology of that relationship even right now. We ask people to stop conflicts, to stop the relationship with drugs, etc., but we don't give them connection in place of that. So coming back to your heart and breathing through your heart region, it's common that people will get distracted and pulled off track as they try to send that to the other person. And as you find yourself mind wandering or you struggle with that, you just return back to your heart, breathing slowly, connecting to that felt sense of appreciation, really reconnecting to that, and then sending that outward again to that unhealthy relationship. This is teaching somebody how to interact differently in that arousal cycle. I'm coming back to my sense of self inside of that. So that's a little practical application for you. When you practice it, it becomes your new baseline, and it can start to show up even in your interaction with that person that you're frustrated with when you practice it outside of that time. So to wrap this up, relational supportive structures. That's what I just demonstrated for you. Ability to work on relationship and fracture aloneness, because for a lot of people with addiction, running away from aloneness has been a big part of their life. So how do we get them to interact differently? Dealing with that root layer dysregulation and healing that to reduce the addiction drive, pushing them to that fire extinguisher. Creating some skill set around this ability to connect to self and self-regulate. and being able to use things like heart lock-in, et cetera, to break unhealthy relational patterns. There's a bunch of books by HeartMath out there, transforming stress, transforming anxiety, transforming depression, are all good sources of these tools to work on reformulating relational patterns, even their relationship and their ability to self-regulate when their relationship with drugs.
Well, thank you all again for your time. Thank you so much, Steve. This was such a great hour. I mean, it just like flew by for me. And I know that a lot of other people were like direct messaging me, just saying that this was a really beneficial experience for them. And I hope that at the end of the day, like we just want to serve our communities, right? And we just want the world to be a better place, and really appreciate everyone coming here to try to grow and do better for the clients and families and, you know, relatives that we love and serve. So really wish you all a wonderful rest of your day. Thanks again, Steve. We'll see you on the other side, maybe in another webinar, hopefully.
You
Have a
bet.
good day.
Thanks, everybody.
Thanks. Bye.